Thank you for joining me for this month's Clinical Update webinar. Today, we will be discussing the highlights and challenges of gabapentin. My name is Dr. Kristin Hillman, and I am a member of the clinical team here at Aegis. We will review gabapentin and highlight the benefits and abuse potential. We will compare data from Aegis from the same quarter between 2 years for overall gabapentin positivity and top drug classes that are co-positive with gabapentin. We will discuss several disease states where gabapentin has shown efficacy. And lastly, we will discuss the increasing prescribing trends of gabapentin. So gabapentin currently has 3 brand names: Neurontin, Gralis, and Horizon. It was first approved by the FDA in 1993 for the treatment of epilepsy, and in 2004 was approved for the treatment of post-herpetic neurological pain. However, almost 95% of gabapentin prescriptions are for off-label use, including for some forms of anxiety disorders, management of pain-related conditions, alcohol use disorder, and others. Gabapentin is structurally related to the neurotransmitter GABA-aminobutyric acid, but it does not have any effect on GABA binding, uptake, or degradation. Gabapentin has also been shown to bind with high affinity to voltage-activated calcium channels. However, the relationship of this binding to the therapeutic effects of gabapentin is unknown. Research continues to understand the mechanism of action for gabapentin fully. Although gabapentin is generally considered safe at low doses, when used with other CNS depressants such as opioids, antidepressants, antihistamines, benzodiazepines, or others, there is the risk for respiratory depression, potentially resulting in death. In 2022, the FDA administered a warning that patients using gabapentin who have respiratory risk factors may have serious breathing difficulties when used with opioids or other CNS depressants. Although gabapentin is not considered a controlled substance by the federal government, it does have a potential for misuse or abuse. As of September 2022, gabapentin was classified as a controlled substance in 7 states, which are listed on this slide. Gabapentin does not exhibit affinity for benzodiazepine receptors, opiate receptors including mu, delta, or kappa, or the cannabinoid 1 receptors, but varying desired effects similar to the activation of these receptors have been reported with higher doses of gabapentin, including improved sociability, increased energy, marijuana-like relaxation, or dissociation. It is thought that gabapentin is primarily misused for recreational purposes, self-medication, or intentional self-harm. Reports to the U.S. Researched Abuse, Diversion, and Addiction-Related Surveillance System showed there was an increase in the annual gabapentin diversion from 2002 to 2015, likely due to the availability of gabapentin from increased prescribing. The prescription rate nearly doubled between 2009 and 2016. By 2019, gabapentin had become the 7th most prescribed drug in the U.S., and it is still in the top 10 today. According to the State Unintentional Drug Overdose Reporting System, from 23 states and the District of Columbia, overdose deaths in which gabapentin was detected doubled from 449 in the first quarter of 2019 to 959 in the second quarter of 2020. Whether we can stop this trend by increasing regulatory control or by focusing more on patient education is yet to be determined. Either way, people who use gabapentin with CNS depressants should be educated about the increased risk of respiratory depression and possible death. Signs and symptoms of gabapentin misuse or abuse can include the development of tolerance, self-dose escalation, and drug-seeking behavior. Because trends in gabapentin misuse and diversion are especially seen in those with a history of opioid abuse, understanding the risk factors of the patient before prescribing can reduce the rate of gabapentin abuse. To better understand the frequency of the use of gabapentin when it has not been prescribed, and the use of gabapentin with other substances, an analysis comparing Aegis gabapentin results in Q1 of both 2023 and 2024 was performed. The overall positivity for gabapentin in both periods for all samples, regardless of whether or not it was indicated as prescribed, was nearly 25%, which is the highest positivity of any drug tested at Aegis currently. The overall positivity of gabapentin in samples not indicated as prescribed was similar in both periods, right at 1 in 10 samples. Because it is possible that prescribed gabapentin may not be indicated as prescribed on samples with regularity, samples in which there were no medications at all indicated as prescribed were excluded. This was done to eliminate potential bias. And lastly, the top 5 drug classes that were co-positive with gabapentin were similar in both periods and are discussed in the following slides. The opioid class was co-positive with gabapentin more often than any other drug or drug class. The co-administration of opioids with gabapentin may cause an increase in both gabapentin and opioid concentrations, resulting in CNS depression, with symptoms including somnolence, sedation, respiratory depression, or possible death. Gabapentin has no direct ligand activity at opioid receptors, but it does potentiate the analgesic effect of most opioids. The combination of opioids and gabapentin has been shown to increase the risk of respiratory depression and has been associated with increased opioid-related death compared to opioid use without gabapentin. And because the high can be accentuated with concurrent use of these two drugs, requests for high-dose gabapentin from patients may be a signal for potential opioid misuse. It has been shown that gabapentin is a highly abused drug worldwide, and those who prescribe gabapentin should be aware of its abuse potential, particularly in persons with a history of opioid misuse. On the other hand, there are many studies that show the benefits of using gabapentin in a multimodal approach to pain management, but this use is in the absence of opioids. Buprenorphine and opioid antagonists are tied as the second most prevalent drugs co-positive with gabapentin. This is not surprising, as buprenorphine and naloxone, which is Suboxone, are often prescribed in the behavioral health community and are regularly co-positive. Because buprenorphine is an opioid, as we have discussed, the co-administration of opioids with gabapentin may result in CNS depression. It is recommended to use an alternative drug to gabapentin or to decrease the dose of one or both drugs. On the other hand, the use of opioid antagonists with gabapentin does not cause any known side effects. Literature is scant on the use of gabapentin in the substance use disorder environment. However, one study found positive results for opioid use withdrawal using scheduled tizanidine, hydroxyzine, and gabapentin instead of opioids or benzodiazepines, followed by an injectable extended-release naltrexone treatment. Benzodiazepines were the third most co-positive drug class found with gabapentin. The use of benzodiazepines with gabapentin may cause respiratory depression or exacerbate the benzodiazepine side effects, such as dizziness, drowsiness, confusion, and difficulty concentrating. Gabapentin does appear to be efficacious in some forms of anxiety disorders. This is discussed alongside antidepressants, which were the fourth most co-positive drug class found with gabapentin. Antidepressants are commonly prescribed alongside gabapentin for depression and anxiety, although when co-ingested, there is an increased risk of hyponatremia and/or seizure. Gabapentin does appear to be effective in some forms of anxiety disorders, such as preoperative anxiety, anxiety in breast cancer survivors, social phobia, social anxiety disorders, and severe panic disorder. No significant benefit of gabapentin has been conclusively observed in the treatment of OCD, PTSD, depression, major depressive disorder, PTSD, or stimulant use disorder. Lastly, amphetamines and alcohol biomarkers tied for the 5th most detected drug class with gabapentin present. There is little literature available concerning amphetamine with gabapentin, except that gabapentin has not been shown to be effective in treating methamphetamine dependence or stimulant use disorder. Also, the use of amphetamine with gabapentin may exacerbate seizures in those who have seizure disorders. Taking a look at alcohol biomarkers, gabapentin is not FDA approved for treating alcohol use disorder, but it is safe and efficacious in treating alcohol withdrawal syndromes, for treating AUD by reduced cravings, improving the rate of abstinence, delaying the return to heavy drinking, and reducing alcohol consumption. Although it is unlikely that one single medication will be effective for all individuals with an AUD, much literature documents that gabapentin is best used in the withdrawal stages. There's still more research needed to develop new, more effective, and diverse pharmacological treatment options for AUD. In summary, gabapentin can be efficacious when co-prescribed in the management of pain or pain-related conditions, AUD, and some forms of anxiety disorders. But gabapentin can be dangerous when used with CNS depressants or in high doses alone. Prescribers may be able to minimize the increasing misuse of gabapentin and improve patient safety by vigilant monitoring and perhaps lowering doses for persons who may be at risk of gabapentin abuse, especially those who have a history of opioid abuse. Additionally, decreases in prescribing of gabapentin would likely decrease the amount of gabapentin available in the general population and possibly minimize diversion. The medical community overall especially must continue to educate patients about the risks of both ingesting large amounts of gabapentin and administration of gabapentin with CNS depressants. The May clinical update and the references for this presentation may be found at the link on this slide. You may also go to our website at aegislabs.com and look under the clinical resources section. If you have any questions specific to gabapentin or any general questions, please feel free to call or email the clinical team using the information at the bottom of this slide. Thank you for your time and attention, and I hope you have a great rest of your day.